Just as an update as we start, as always, we have 249 people who have tested positive for coronavirus since the beginning of the public health emergency. Of these, only one is currently in the hospital. 33 people who have tested positive have died. As I've said before, not all of those have been, some of those were post-COVID, and we're still awaiting a final determination from OCME for 5 people, whether it was actually a COVID-related death. 133 people required no inpatient care, and 82 were hospitalized and have been discharged. In terms of the kinds of placements those people were living in, 4 were in host homes, 86 were in intermediate care facilities, 21 were in their natural home, 2 were in nursing homes, 27 in residential habilitation placements, and 109 were in supported living placements. As I indicated last week, our numbers regarding provider staff have gone up because we work really closely now with DC Health and with our providers to make sure that we're getting a full count of provider staff who have tested positive. To date, the number that we have is 314 provider staff have tested positive, which includes 29 people who work at more than one provider location. And unfortunately, we have lost 9 provider staff to COVID-19. We actually received no questions for today. We did send out yesterday some guidance regarding the employment readiness service. Folks who are currently in employment readiness, we sent out some guidance from RSA regarding job readiness as well as discovery, because either of those services could be provided via RSA for people that, where it may be appropriate for the person to get job readiness, but you want to provide that virtually rather than in person. And we have the issue of being able, if they are getting a current waiver service or some other Medicaid service, or they're in a placement where they require support from someone that's paid by Medicaid. As people are aware, you can't bill for 2 Medicaid services at the same time. And so through RSA, people can do job readiness. What's explained in the information that we sent yesterday is the number of hours that can be billed on one authorization for job readiness. Job readiness in the RSA Human Care Agreement is intended to be 2 weeks, but the 2 weeks is a number of hours, and those number of hours can be broken down in any manner whatsoever. It is group job readiness and can be a group of between 4 and 12 people. It can, the 2 weeks can be up to, I think it's like 6 weeks, depending on how you break down the hours. What we'll be asking from people, from providers, is that some description of the curriculum of exactly what it is that will be covered in these job readiness sessions be provided. And so then the authorization will be issued. The VR counselor will be monitoring the person's progress and then can authorize for an additional session of job readiness. The other thing, which is not in that guidance, but which we've gone over before, is just a reminder that with the waiver renewal in 2017, there was a 2-year limit on people receiving employment readiness services in the waiver. And so job readiness is not a way around that limit. If people have reached that limit, they need to identify other waiver services that they would use during that time. And so, and the other thing that I've talked about, and I think Daryl Evans spoke about last week, is that there will be, well, we're hoping a more and very intentional focus on job readiness as preparing people for the workforce. The reason that we impose the limitation of 2 years on employment readiness is, as I have told people, the best employment readiness training from my perspective is a job. And, the best way to learn good work skills is to practice them. And so, what RSA, my hope is they will be the VR counselors in working with each of the providers and with the teams, with the people who receive job readiness, will be very focused on how this service is moving this person toward employment, because that's the goal. It is not the goal that this person has this number of hours to spend on day services during the week, so let's spend some of them on employment readiness or job readiness. This is about a person having a goal of working toward employment, and job readiness training is part of preparing them for that. I'm noticing already that the only question I see relates to something for which I'm not certain whether we have the person included as a panelist. So I want to make sure that Donald Clark is included as a panelist so that he can answer the only question I've seen so far. If people have any questions, please, you can type them in and we will respond. We can start accepting plans from folks. I think that went to everyone. I'm not sure. No, it didn't. So we can start accepting the plans, the curriculums from the employment readiness, from folks that want to do job readiness with RSA beginning on Monday.
Hello there. This is Donald Clark. I see a question from Allison White. I think you've discussed this before, but can you clarify again how assistive technology waiver service is working? On waiver funds, can waiver funds be purchased to purchase tech itself, such as iPads, laptops, etc., if an assessment deems it's necessary to achieve a person's goal? Allison, great question. What I was referring to last week was in fact that an amendment has been made to assistive technology services under the waiver. That amendment actually goes live in November. What that amendment does is it enables for providers to actually provide the assistive technology services. And that will help streamline the process to, yes, get such pieces of technology such as iPads or laptops. We wanted to change that to make it more of a shift to a team approach, first and foremost, prior to solely going to clinicians to make those determinations. We want that to be led by the person, their provider, and their service coordinator to see and deem if it's necessary. Of course, with also taking in consideration the opportunity, if need be, if decisions can't be made at that level, for them to still work with those clinicians to lead to that determination or assessment if needed. So I hope that answers your question. If not, feel free to follow up with me. We can further discuss. I'd like to also say my unit colleague, Chanel Parker, worked very closely with me to make sure that we made this amendment in the waiver. So may loop her in, but I'd be happy to further discuss.
Correct. Donald?
Yes, I see. Thank you so much. So that, yes, starting November 1st, as far as me speaking to the providers being able to take the lead with the AT services, just to be clear, in November. In terms of assistive technology, is it correct that waiver funds themselves, even in November, cannot be used to actually pay for technology? I'm not quite sure.
No, that's not correct. Can people not hear me?
I can hear you now, Andy.
Oh, okay. So what is the amount up to which we will reimburse providers for technology?
Uh, I need Chanel on this. I believe it's a 5-year period. At the max of, is it 5,000 net or 10,000? I'll have to look back at the waiver to see that.
But the way that the waiver is constructed, contrary to what the person is asking, is that in fact the providers can purchase technology and we reimburse the provider, correct?
Correct. But I just want to emphasize on top of that, that will be reflected in the waiver amendment that goes live in November, just to be clear.
That is
Yes.
expected to go live in November.
Yes.
Just
Correct. And the amount is 10,000 over a 5-year period. To answer Morgan and Allison's question.
okay. Next question. There was a question I thought.
For people who are living in rehab or supported living settings, are they still being asked to be 6 feet or more apart from each other at meal times? They essentially share a household.
So I'm going to ask, we have Daryl on the line, but I also, as we were answering the last question, pulled up the guidance, which I would invite people to do. And I'll read what I'm seeing in the guidance, and then I'll ask Daryl Hawkins if she can supplement that at all. But what I read in the guidance that was issued regarding phase 2 guidance for supported living and community residence facilities, which is published both on DDS's website as well as coronavirus.dc.gov. Practice social distancing. Keep 6 feet of distance between you and other people who are not living. It says not in your household, but it means living in your household. So, Daryl, if you want to supplement that response or in any way.
Yes, that is, Director Risa, you're correct. When we say not in your household, we mean those that are not your household members. Additionally, I know that the question was for rehab and supported living settings. I do want to also say that in the ICF document, we are in the process of clarifying the wording there. To make it clear that those that are in the households, individuals living in the household or in the home or in the residence, are not, we're treating them, that's their home, their household members. So they do not have to maintain social distancing from each other. We understand that that's their home. However, we do want to still encourage those that are healthcare personnel or direct care providers in going to the supported living or rehab or ICF settings, that they are not from that household, they don't live there. They should still maintain that social distancing and masking as appropriate, so that they can protect those living in that household and protect each other from other DSPs or other direct care providers from each other, which is one of the other exposure things that we find. So,
Thank you.
yep.
Any other questions? Please type that in the chat box.
So there is a question for IDS providers. Our understanding is we don't have to complete a reopening procedure and protocol as day facilities are required to, and have the plans approved by DDS Quality Resources. That's correct. It is an individualized service, and so our expectation is that the description of what those services look like are going to be different for every person for whom you're providing them. The team should be reviewing the community participation assessment and questionnaire and developing a plan with the IDS provider about kinds of activities the person engages in. So that's where that whole discussion would occur. And I think that questionnaire helps guide you through some of the questions that you would have about how the person is engaging in the community. I have heard from some providers some concern that there isn't guidance on this. So as I've said, as we now the day program reopening plans are now available. They're being shared. We are starting to schedule and have our interdisciplinary team meetings. So if, as we have those, if I learn that it's incorrect, that we do need to provide some more general guidance for everyone on top of the individual discussions about each person, then we'll work on that at that time. But for right now, I believe that with the community participation assessment questionnaire and the interdisciplinary team meetings, that we should be able to get to the kinds of conversations we need to have about how the person engages safely in the community, how this service can help them engage safely in the community.
The last time we heard from DC Health was that they would get back to us to clarify the use of face shields at all times while in the facility, even when no aerosol therapy is involved. Can you please clarify again?
Hi, this is
Oh, good. Go ahead. Sorry.
great. Yeah. So this is Zero Hawkins again from DC Health. I can give an update on this. Right now, I will give a summary of what is currently in the guidance right now for your facilities. For ICF, eye protection is required in the supported living and CRF guidance. It says can consider the use universal eye protection. I do want to say that right now, DC Health is working on a PPE guidance across all many different healthcare settings, including ICFs and supported livings and CRFs, because pertaining to eye protection. And that has not published yet. I think it's still in draft process. So I do want to say that that is going to be updated shortly. We want to emphasize that that eye protection is one of the many important prevention practices to protect individuals, residents in the home, and staff that are working in the home from each other. So, and also if there are positive residents from residents. But so eye protection is important because it protects the mask. Universal masking protects your mucous membranes, which is your mouth and your nose, but the eye protection adds that other piece, which is your eyes, which is those are the different ways that we can get COVID into our body. So because of that, we are going to be updating that PPE universal eye protection guidance across all different settings. And I just wanted to make your providers aware. But as it stands right now, the guidance says ICFs, it is required in CRFs and supported living, strongly consider. So that's my summary right now, but I think we're moving towards requiring it in all patient or in care areas in across different facilities, but that's not official yet.
DDS SCs are not approving retainer payments anymore. They say that they are told that retainer fees stopped. Is DDS SC aware that Appendix K updates to include 90 days for retainer fees?
Yeah, but I'm not even clear about what the service coordinator's role is in approving a retainer payment, to tell you the truth. I want to see if Musu or Shasta are here to be able to respond to these questions about service coordination. So I do see that Musu is here. If she's actually, oh, and you get a little exclamation point if it says here, they're not really paying attention. So it appears that she's here and listening. So if it's possible to make Musu, there, she's a panelist. So Musu, if you're available to respond to some of these service coordination questions, please. You're still on mute. If you heard the request.
Okay, can you hear me now?
Yes, thank you.
So service coordinators are not approving the retainer payments. That's not something that service coordinators have been doing or are doing at all. They don't have any role to play in that process.
Except that the way to be eligible for a retainer payment is that day services are authorized but not used. Is there some question about whether day services continue to be authorized although unavailable? Could that be the root of this?
Well, day services stopped being authorized sometime in March for all people. I mean, even though we kept the authorization, we moved everyone over to companion and in-home support, and that was in March. And that's been way over 90 days at this point, so.
Right, but I'm thinking that could be the root of the problem is that under the Appendix K, a person has to be authorized for day services and unable to attend because of the public health emergency, and that makes them eligible for the retainer payment. So it could be that. So we will discuss this internally and make sure that there's not something else we need to be doing and then let service coordination know. Because the reality is they don't need to authorize a service for the person to get a service, but it may well be that they need to have the authorization in the system to make them eligible to get payment for not getting the service. So we will make sure that that discussion is had and that, you know, whatever authorizations need to be there so that people can get the retainer payments is that is done.
Are there any additional questions?
There are follow-up questions I would like Musu to answer regarding people being able to access individualized day services, because people are saying that someone said, can we have this exemption in writing regarding IDS, regarding individualized day services, about them not needing to have a reopening day plan in place. I think the confusion there could be that in order to begin discussing day services, we needed to make sure that all day services were available to begin the discussion. But perhaps Musu could speak to, I think you can see the questions here, Musu, regarding.
No, let me see if I can pull the questions up.
They seem to all be sent, not sure why, privately. So when you send questions, if you type in questions, please type in your questions to everyone. If you type it in, so make sure that you send to everyone rather than just to me. That allows everyone to see what the question is, so that we can make sure that the right people are answering it.
So I see a question about, last question I see is about the retainer payments. So the question.
Here we go. I'm going to copy this and type and paste it so that you can see these.
My understanding is that and again, you know, Kwapna can speak to this a little bit better, but definitely we were looking for a plan from IDS programs as well, because there are questions about when you have people out in the community, what do you do about sanitization if people need to use the restrooms, about extra masks, if a staff person doesn't come to work or you have to change a staff person, what kind of advance notice is given? What are your protocols? And these are all questions the teams are going to have when those CPAC meetings are scheduled. And so part of what we were looking for was for IDS providers to also submit their plans to QAPMA so that at least we know that those basic assurances are there in terms of precautions that are going to be taken for people. And that when we meet as a team within service at the CPAC planning meeting, we're looking more at the programming. What is the schedule going to look like? Where are you going to be taking the people? What mode of transportation are you going to be using? So yeah, we were looking for the plans for people in IDS as well.
So we're going to need to have internally that discussion and make sure that it's clear to everyone what needs to be provided. Because I know that the concern we heard from people is that when you read the plan outline, that it's very much about a day program facility. And that there's really only one question there that relates to the community. And so if we have providers who do just IDS, what exactly do we need from them so that we can move forward on this?
Yes, that would be helpful.
So unfortunately, Kirk is not here today, but we will make sure that service coordination and QAPMA are on the same page and communicating the same thing to everyone on Monday.
Okay, so there's confusion. Hold on, my chat is jumping right now. Does a provider need to provide a retainer payment attestation for every program they offer? Do we need one for every person served? Is there a specific form? If so, where can we locate it?
There is not a specific form. The attestation required is what's outlined in the Appendix K. And so it would need to be submitted with each claim. So, that may well mean, you just make copies of the same thing over and over again, just clarifying that you're not paying for this from more than one source, that you have retained the personnel, the required attestations there.
Okay. And DC Health has changed the requirements of face shields. 2 weeks ago, we were informed that face shields were not required in homes unless it was a COVID-19 exposed home or confirmed diagnosis. Continuous of face shields and surgical masks is tremendous financial burden on providers. Please clarify the requirements for ICF homes and continuous use of face shields again.
Hi, yes, this is DC Health. So again, hopefully when the PPE guidance comes out, it will make things a little bit more aligned and less confusing. So in the supported living and CRF guidance, it says that eye protection should be considered, and it does mention eye protection should be considered. Direct care staff can consider the use of universal eye protection if there are suspected or confirmed COVID-19 persons living in the residence. So that's for CRFs and supported livings. But in the ICF document, it does say that staff should wear universal eye protection, not just when there is somebody who has COVID-19 in the home. So more universal eye protection. But as I mentioned, we are, because of the reasons that I mentioned in terms of how COVID-19 is transmitted, that PPE requirement for universal eye protection is potentially going to change in the coming weeks across many different settings because of the importance of how it does reduce transmission in many different settings that we've noticed. And then to address the next question, we do understand that is, with the new requirements of universal masking, universal eye protection, potentially if you're an ICF, and as that guidance changes, we know that that's that is extra cost to different healthcare facilities, to your settings. We do want to say that if you're having a difficult time getting those supplies from your normal supply chains, or if your supply chains are not your typical supply chains, making it difficult to reach out. I know that HCMA does have some emergency use supplies available. It's not to sustain for the duration, but can kind of abridge that if you're having a tough time with that supply. So, I don't know if anyone else from if Director Reese, you want to add anything else in terms of the cost portion?
No, there really is nothing else we can add to that. Thanks.
Okay. In regards to the Appendix K, Section E, a brief description of emergency, is this paragraph for everyone in service or for services such as ER, IDS, and DH?
I have to look at exactly what you're referring to. Excuse me a second while I open it up to see what Section E is referring to so that I can answer your question. Oh, this refers to the Appendix K. So the Appendix K is a description of the emergency that allows us to have this flexibility. And so, this emergency relates to the COVID-19 pandemic, and the proposed effective dates of the emergency are March 11, 2020 to March 10, 2021, and it applies to the whole Appendix K. So the effective date of the whole Appendix K is the whole year, keeping in mind that retainer payments are limited to no more than 90 days of service within that year.
Okay, my screen is jumping again. Hold on one sec. So DDS SC say they will not do the team meetings or any services as IDS is a day service and day service is not open. That was their directive. Is Musa still online?
We will clarify, as I said, to ensure that QAPMA and service coordination are on the same page. And on Monday, we will send something out, making sure that that's clear. So I see the next comment is about also service coordination, not understanding that an authorization needs to be in place in order for a provider to bill for a retainer, because you get paid for the retainer because the service was authorized and cannot be provided. And it is, up to 90 days of service. It's not a 90-day period, which would have lapsed quite some time ago, but 90 days of service.
Under visitation and community outings, under Phase 2 operating status, it states that providers are prohibited from issuing blanket bans or restrictions of such rights. This refers to people who live in residential, HAB, and ICFs, limit going into the community and having visitors. This does not mean such activities are completely prohibited. It also states that people supported by DDA have the right to go into the community, have visitors within and outside their home, and go to visit family members and friends. This states that people are allowed to visit their families, correct? So in what instances is this visitation not allowed? Because I am told there are constraints on visits.
So when I've described the visits before in terms of the different placements that people live in, the way to see it is that as the guidance currently reads, in an intermediate care facility, the default essentially is that there cannot be visits within the home. But there are exceptions to that, in that, in exceptional circumstances, you could have a visit in the home where it could not be facilitated outside. In all circumstances, there's a stated preference for having visits outdoors, outside, because it is safer to be in an open outdoor setting in terms of transmission. In all settings, you need to make sure that, so if someone's coming to the home, that they're screened, that social distancing is paid attention to, and that face coverings are used. For residential habilitation, there is a preference that it be outdoors. It can be in the home, but if it is, there's then a preference that, or an expectation really, that it should be separate from where everyone else in the home is. So if you're in a home and it's a residential habilitation placement and you've got 4 people living there, that there's some area set aside where they're visiting, or that they're visiting in the person's room, so that people are coming into contact with as few other people as possible. So, where you read, let me also say this, and I think what's important in the language is providers are prohibited from issuing blanket bans or restrictions of such rights. Any limitation on a person's rights. So first of all, under her public health authority, the mayor can restrict all of us, and has in certain ways. So the mayor can require that all of us, when we go out, wear face covering. She has established requirements in our building that, if I'm outside my office or if I am in an open air office area, I have to wear a face covering. That is within the mayor's public health authority. Providers don't have that kind of authority. So, providers can't ban these kinds of things, but they can talk with people about the bans that exist or the restrictions that exist, or, have discussions with people about what is it that, what are the current recommendations, and how can we help you to do what it is that you want to do in a safe manner. We have started having the discussions with provider agencies around people's rights during COVID, and we should be scheduling soon those discussions also with our next meeting of the group that has developed that PowerPoint and is helping with facilitate those discussions. Our next meeting is a week from Tuesday, and I think one of the things that we need to start talking about is how we can also be facilitating those discussions with the people we support and their families, so that they are also aware of this. But we focused initially on service coordination, and we're working now with providers so that everyone is aware of how we do this balancing of helping people stay safe, and ensuring that we're doing it in a way that respects their rights.
Sorry, maybe I didn't understand your answer for the question around the Appendix K. Do we need to do a paragraph to accompany the attestation form when we submit the retainer payment for each person?
While we were discussing that, I'll just let people know in the interest of transparency that I sent an email to the folks here to say that I think that our transmittal needed more detail on the retainer payments and the attestation that's required. And so I've asked them to work on that next week because, and just got a response that they will be. So I think that we need to provide some more clear guidance, especially to address a couple of things. I mean, to address a few things. One, exactly what the attestation is. How do we make sure that there's an edit in place so that DHCF doesn't just pay things without the attestation having been provided? How do we make sure the attestation is adequate? How do we make sure that service coordination is aware of the need to have an authorization out there so that the retainer can be paid? So I think that we probably need some better guidance on that. And I've asked people to pull together. I don't think it will take, that should not take too much time to be ready next week so that people can have a clear idea of exactly how to do all of those things. Also keeping in mind, retainer payments prior to the changes that came out from CMS June 30th, you follow all the rules that existed before. And so, to the extent someone had been scheduled for the sort of traditional 5 days a week, 6 hours a day, you would have gotten close to 90 days of service by June 30th. And all of these new requirements only apply to services authorized after June the 30th. So there's a great deal of payment that can be made for retainer payments from the old system of just putting in an invoice for the retainer payment based on the authorization that existed pre-June 30th.
So in regards to the question with visits, I understood the question as visits to family, not from family. Can you please address this, what Quintina had asked?
Oh, okay. So I think that this will be a mix in terms of, well, first of all, yeah, people have a right to visit their family. Let me say that. Next, I think that when those plans are made, there really does need to be a discussion with the person and their family about what this visit looks like. And that's not, with the thought of because we're going to impose a restriction on it, but we do need to understand a lot of things. First of all, if you read the ICF guidance, it suggests that people really shouldn't be, that any visits currently should still be occurring outside at the place where the person lives. And the concern there is, you have up to 6 people. If they're traveling out into the community to visit with their family, how many people are they having exposure to? And then going back to the home and interacting with the other people that live there. With that said, I think that there needs to be discussion in every instance about, visitation, how someone can safely visit with their family. And I guess the reason I don't distinguish real clearly between from their family and to their family is that to me, it's with their family. And how do we together have a discussion about how to do that in a manner that's safe, that also keeps in mind the health of the people that everyone lives with. Because the visits can occur, but at the same time, what are we talking about? You know, is it that we want to make sure that there's this big family birthday party for someone and we want to include this person in it? And if that's the case, has there been a discussion about, you know, how are we making sure that there's safe social distance between all of these people? So I do think that question can become a bit complex, but I think that the question of visits with family are visits with family, and then we have a discussion about, is it to the family or from the family, and how does that happen safely in any instance? And I see a comment that providers are still imposing blanket restrictions on visits to family. I think, and Daryl, I'll call on you again. I think that a provider imposing a restriction for a person in an ICF on a visit to their family is a reasonable reading of the phase 2 ICF guidance. Would you agree?
Hi, this is Daryl Hawkins.
Let me pull it up.
Yes, currently, in the ICF guidance, as Director Riso nicely summarized, in ICFs, we do want to limit individuals in ICF's exposure to those in the community to kind of reduce their risk of COVID-19. So the answer is yes, but we do want to say that outdoor visitation, we do want individuals who live in ICFs to still see their families, and the way that they can do that in the safest possible way is to do it outdoors at the ICF and with their family members, and we encourage that. But to their family's home, as Director Reese stated, that is during phase 2, not it is restricted.
But I think if such a blanket restriction were being put in place in a residential, for a person who's in a residential habilitation or supported living, that does go beyond even that guidance.
Correct. In CRFs and supported living residences, individuals can go and leave their homes, and there's certain things that we say to consider to try to make it safer outing to the community, whether it's to their family's home or to other things. But yes, correct. If you were to restrict those in ResHab, CRF supported livings from going to visit their family at their homes, that is beyond the DC Health guidance. That goes beyond that, yes.
Thank you, Daryl. Has there been any discussion or guidance about visits to day program buildings when they reopen?
Visits by whom? If the person who had that question, visitors to day programs, I don't know who would be a visitor to a day program. I mean, and maybe some of our day providers. Well, I guess I can think of an example actually. You know, and I think this could be one of the challenges. I don't mean to call on people, oh, and you're not a panelist, so, but if you could type the answer. An example I can think of is that Tony, Art Nables, is both a gallery and has people who are there working during the day. And maybe you could describe for people how they manage that. And I can also look to see, I think that our guidance addressed this question of visitors, probably to say there shouldn't be any, but I'm going to look and it may be that the DC Health guidance addressed it as well.
Yeah, our DC Health guidance does mention visitors. We didn't specifically restrict visitors, but it does say that all adult day program participants and visitors must be screened before entering the facility each day. And it goes into the different screening and exposure checks and temperature checks, et cetera.
And I'm just going to see if the DDS guidance on day addressed this. And if Tony Brunswick, thank you. So their program is actually closed to the public currently, because as a gallery, I guess you could be open to like a limited number of people coming in, right? And so, you know, I kind of struggle to figure out who would be a visitor in a day program. But as Daryl is saying, you know, anyone who comes in should be screened. And we will actually be visiting some of the day programs, because one of the things that I'm really curious to see, to confirm, is ensuring social distancing as people arrive and depart. Just as a heads up there.
And we want to mention, as Director Reese discussed, any individuals in the adult day program, visitors, participants, et cetera, social distancing should be enforced, and also wearing source control, such as cloth face coverings for any of those visitors as well.
So people are saying an attorney, a monitor, parents, guardians. Well, I'll tell you, as like for DDS, and I know DC Health, if we show up, there really better be screening. So, you know, that is certainly one of the things that we're going to be looking for if we were to stop by. I expect that someone else, if you know, if you are an advocate for someone or a family member, I guess there's the possibility that you would also want to stop by. I would caution people to keep in mind, just in terms of when you stop by, and you know that that the numbers of people being, you know, visiting places is going to be limited, just because the number of people in a placement is limited. But I certainly understand, and no one would suggest that we are trying to limit someone's ability to stop by and check up on services being provided to their family or to someone they represent or, you know, are an advocate for. At the same time, our quality folks, I know quality folks from Quality Trust, DC Health, have been managing to do some of that work, to do all of that work or most of that work virtually, by having a you know, a FaceTime call saying, I'd like to see where my family member is. Can I see who else is in the room? And I would really encourage people to think about that.
Hi, this is DC Health. I just want to emphasize, if for anybody who's going to an adult day program, whether they're participants, visitors, staff, universal source control, whether by face mask or cloth face covering, social distancing, as Director Reese mentioned, and any visitors that do come or participants that do come to the adult day programs, if they are, if they attend an adult day program activity, that they notify the facility if they test positive for COVID-19, so that that facility can then initiate contact tracing. So hopefully that doesn't happen, but I just want to mention that as a consideration for any individuals going to the day programs, whether it's visitors or participants, et cetera.
And just to clarify for people, and to correct a little bit. Part of the provider's reopening plan needs to include a separate protocol for monitoring visitors, staff, or participants. So there needs to be included in the plan what their practice will be for the screening of visitors to the placement. So it is anticipated in the plan, needs to be anticipated in providers' plans. So providers would not be saying no, but there is the expectation that there be separate facilities for visitors, that visitors be screened when they get there. And as Daryl is saying, absolutely. I mean, anyone who comes into the facility is using appropriate protective equipment and maintaining the appropriate physical distance from others. I do see that Tony, he sent it to everyone. Their gallery is open weekends only. So that people are aware they are open on the weekends. And a suggestion that perhaps providers could contact the service coordinator to work through any questions about visitation rather than saying no. And as I said, in their plan, it should really identify here's how visits are handled. I do think it's probably important that people be aware of arrival and departure times. I mean, one of the challenges with day programs is not having a line of people in the morning. So, being aware of all of the need to keep distance and ensure the safety of everyone that comes in. For any visits to a day program, to a home, from a home.
Any other questions? We have a couple more minutes before we wrap up.
So I don't see other questions. Before we end, I do just want to kind of let people know there are two things that we will be following up on. One of these being there'll be a discussion on Monday between service coordination and QAPMA about what is required in terms of day program plans for providers who provide only, I guess, individualized day services. And what needs to be done so that service coordination can move forward with individualized, with the interdisciplinary team meetings in order to discuss beginning services. And the operations and service coordination will be discussing sending out some clarification to our transmittal regarding the retainer payments so that all of the questions we've gotten here are answered clearly in writing for people.
Okay,
So
just the
very
last.
quickly. Yeah, I see that. I want
You
to
see it? Okay.
go back to the guidance. So I think that the comment is Oh, wait a minute. So regarding visitation provisions of the DC health guidance, it doesn't appear to clearly prohibit residents from ever visiting their family at the family's home. It states visitation inside a facility is generally prohibited. It only anticipates visitation occurring at the facility, and I think that it includes visitation with the family, or it contemplates the guidance under field trips / group activities, I believe, to address the issue of visitation outside the placement with family. And Daryl could correct me if I'm wrong there, but I think the way I read this overall is that the only expectation regarding people leaving the facility is the guidance regarding leaving for medical reasons and field trips / group activities. And so when you read those, that's where you get to the idea that to the extent possible, you're not seeing people go out.
That's correct, Director Reese. I don't know if you could hear me, but yes, Director Reese, that's correct.
Right. And so the, and it's now 1:06, and my person who is in my 1:00 meeting is wondering where I am. So we will be talking with all of you next week. Thank you.